Good afternoon, everyone, and welcome to this Kidney Action Week session on APOL1-Mediated kidney disease, also known as AMKD. My name is Mike Spigler, and I'm the Vice President of Patient Support and Education for the American Kidney Fund. Today's session will give you valuable insights into AMKD and its impact on kidney health. We will also discuss existing research and initiatives being done by both the Kidney Health Initiative and the American Kidney Fund. And most importantly, we'll provide you with action steps that you should take to improve the care of your patients. Now let me introduce our speakers. First is Dr. Mona Doshi. Dr. Doshi is Medical Director of the Living Donor Kidney Transplant Program at the University of Michigan. Dr. Doshi's research interests include understanding the impact of the APOL1 genotype on donor outcomes. She is one of the primary investigators on the NIH-sponsored APOLLO study and is co-leading a work group on the psychosocial evaluation of living donors, particularly those with a history of substance use disorder and mental health disorders. Dr. Doshi is passionate about removing financial disincentives to living donations and works with state government efforts to remove some of those barriers. Next is Dr. Aptal Patel. Dr. Patel is Chief Medical Officer at HiBio. Prior to HiBio, he was the head of Clinical, Renal, and Executive Group Director in early CVRM at AstraZeneca, where he led early clinical strategy and development for a wide range of therapies that address several kidney diseases. He previously led the kidney diseases domain at Gilead Sciences. He currently also serves as chair of the board of directors for the Kidney Health Initiative. As a faculty member at Duke University, he led clinical and translational research programs to improve detection and management of kidney disease in populations. We've got a lot of information to get to you, so we're going to jump right in. So I'll turn things right over to Dr. Doshi.
Oh, thank you. Thank you, Mike. And I would like to kick off by welcoming the audience and thank you to American Kidney Fund for inviting me to share, where research is so far with regards to APOL1-mediated kidney disease. Here are my disclosure. As Mike already alluded to, I'm the PI on the NIH-sponsored APOLLO study. So next slide, please. Okay, so for today's talk, I will give you an overview of APOL1 gene and its role in development of kidney disease. Thereafter, we'll review the impact of APOL1 kidney risk variants in different clinical settings. So native kidney disease, kidney transplants, and then as it pertains to living donors and family members of those who have APOL1-mediated kidney disease. At the end, I will give you an overview about current research initiatives, and lastly, end with some action steps for the providers. Next slide, please. So as we all know, right, Black Americans constitute only 13% of general population, yet 35% of Black Americans suffer from kidney disease and are on dialysis. The recent GWAS study, right, which is looking at gene association with diseases, in 2010 found an association between APOL1 genotypes and risk of kidney disease seen in African Americans. Next slide, please. And since 2010, if you see, there have been several studies, case control, cohort studies, population studies, indicating that there is an association between APOL1 kidney risk variants and development of kidney disease. So let's talk a little bit about APOL1 kidney risk variants. Next slide, please. So APOL1 gene is coded on chromosome number 22, okay? And this gene was mutated or change in that gene occurred to protect human beings from trypanosomal infection. So individuals in sub-Saharan Africa were succumbing to this infection that led to sleeping sickness and eventually death of that individual. So Mother Nature is trying to protect us from this nasty infection, and as a result, individuals residing in sub-Saharan African region had a mutation in APOL1 gene. And what you see here is if the individual had one risk variant, then they were able to fight off trypanosomal infection. If individuals had two risk variants, on the far right side, you see, they were also able to fight off trypanosomal infection, but unfortunately, individuals who had two risk variants of APOL1 gene were also susceptible to kidney disease. As you see the cartoon, where the individual carrying two risk variants is now on dialysis. So while APOL1 gene, changes in APOL1 gene occurred to protect individuals from sleeping sickness, unfortunately, individuals carrying two risk variants develop kidney disease. So later on in the talk, I refer to these individuals carrying two risk alleles as high-risk genotype because they are at high risk for developing kidney disease. Next slide, please. So what is the prototype of this kidney disease, right? What is the prototype of APOL1-mediated kidney disease? So this is a microscopic picture of your kidney. As you all know, what is the role of the kidney is to clean your blood. There are a million nephrons, a million filters in your kidney that help to clean the blood, okay? And these circles that you see in the middle are those nephrons or filters, right? And the dark pink is not good stuff, right? It indicates that the filters are damaged. So originally, we used to call kidney disease in Black individuals with hypertension who had kidney disease, who were landing up on dialysis, as it was mediated from hypertension, therefore the name hypertensive nephrosclerosis. Now it is known that it was not just hypertension, but it is the result of APOL1 gene variants that cause this prototype of disease where the individuals, the filters are damaged as seen by this pink substance. As a result, they leak protein and they have premature kidney disease that a lot of them need dialysis. Now, APOL1 gene has been implicated to hasten the progression of FSGS, focal segmental glomerulosclerosis, that just indicates all this extra pink stuff in the nephrons, or also is proposed to increase the hasten the development of HIV associated nephropathy shown in the extreme right hand side. Next slide, please. Now, let's look at the worldwide prevalence of APOL1 kidney risk variants. So as I mentioned before, APOL1 gene evolved to protect individuals living in sub-Saharan region from sleeping sickness, right? So the green dots here show where the APOL1 is absent, and the dark magenta dots show where the individuals reside and they have care and these individuals carry high risk variants. So let's focus on where are these dark magenta dots. And as you see, they are in West Africa, but you also see them in Africans residing in North America, Africans residing in Caribbean, Africans residing in Brazil. So what this map shows is the prevalence of APOL1 risk variants follows the migratory pattern of the individuals as they left sub-Saharan Africa and migrated to other parts of the world. Okay, so the reason I wanted to highlight this is just cannot look at a person's skin and assume that whether they have APOL1 or they don't. While African Americans, Black individuals from America, do carry this high risk variants, but such high risk variants are also present in Black individuals from Brazil and as well as from Caribbeans. So just a point to make when you are taking care of patients in clinics. Next slide, please. So let's delve a little bit about this gene, right? I told you why the APOL1 gene had some changes was to protect individuals from infection. So each one of us have two copies of APOL1 gene. We get one from mom and one from dad, okay? The variants are inherited in autosomal recessive pattern. That means you need two copies of the changed gene to have kidney disease. Now, APOL1 risk variance is an ancestry marker. It does not have 100% penetrance. That means not every individual carrying two APOL1 risk variants is going to develop kidney disease. So if you look at this cartoon that I borrowed from the Apollo study, in the yellow box, you see There are 5 individuals. All 5 are carrying 2 APOL1 risk variants. But what you see is 4 of them are not going to get kidney disease. Only one individual out of the 5 who are carrying 2 risk variants is going to get kidney disease. Okay? So unlike other diseases that have autosomal recessive pattern, that means you need 2 copies of that gene to get kidney disease. With regards to APOL1 mediated kidney disease, even if you have 2 copies of the mutated gene, not everybody will get kidney disease. Only 1 in 5 or 20% of folks carrying this high risk variants will develop kidney disease. Next slide, please. So, what are the proposed theories for APOL1 mediated kidney disease? As I mentioned, not every individual carrying these risk variants is going to get kidney disease. There has to be a second hit. The second hit can be a virus like HIV or COVID infection. A lot of individuals, we had case reports of individuals, Black individuals, who had worsening of their kidney function after COVID infection, developed actually collapsing FSGS, and later on, when we genotyped them, we found them to be carrying 2 APOL1 risk variants. And therefore, viral infection like COVID-19 was also thought to be responsible for APOL1 mediated kidney disease. A role has been proposed by either environmental factor and even by genetic factor. Recently, there was a gene proposed that protects individual carrying 2 APOL1 risk variants from getting kidney disease. So again, why not all individuals carrying this high risk variants develop kidney disease is because you need a second hit for the individual carrying 2 risk variants to manifest disease. Next slide, please. So how does carrying 2 APOL1 risk variants in presence of a second hit cause kidney disease? There are several theories proposed where it could be because of the mutation of APOL1 gene causes increase in cation transport, and as a result, the cell does not causes injury to the cells in the kidneys, particularly podocyte. It is thought to lead to mitochondrial dysfunction or to lead to endoplasmic reticulum stress. So there are a lot of theories proposed, but one of the most important theory that is thought to play an important role is thought due to that APOL1 results in gain of function, gain of channels that eventually cause premature death of podocyte. Podocytes are the cells that surround those filters and prevent leakage of protein into the kidney space, into the urinary space. When these cells are damaged, the protein leaks out from the capillaries, from the filters, and you see protein in the urine of the affected individual. Next slide, please. So I wanted to share the effect of APOL1 gene on the spectrum of kidney disease. Not all kidney diseases are affected by presence of APOL1. APOL1 seems to hasten the progression of certain kidney disease, as shown on the left-hand side, showing the large effect, right? FSGS, HIV in Africa, HIV in US, hypertension-related ESRD seem to be influenced very, very heavily by presence of APOL1 genotype. However, on the extreme right, where you see diseases where APOL1 has little or no effect, IgA nephropathy, diabetic kidney disease, it appears that APOL1 does not have that strong of an influence in causing progression of kidney disease. Next slide, please. So with this background, now I'm going to talk about what is the influence of APOL1 high-risk variants or APOL1 genotype on progression of kidney disease in general population. That means individuals with native kidney disease, right? So next slide. So the data comes from 2 major studies. First study is the AS study, which is African American study of kidney disease and hypertension. So what this study did is it looked at progression of kidney disease or doubling of serum creatinine or need for dialysis in Black individuals followed from enrollment to around 10 years post follow-up. they genotype these individuals for the APOL1 risk variants. So you see on the left-hand side, let's first focus on the left-hand panel of the figure, figure A. What this figure A shows is the percentage of patients free from doubling of serum creatinine or free from needing dialysis based on number of copies of APOL1 risk variants. So you see the two top dashed lines represent individuals carrying 0 or 1 risk variants, and the dark line at the bottom shows trajectory of people carrying 2 copies of APOL1 risk variants or the high risk genotype. What you see here is that individuals carrying 2 copies of APOL1 risk variants are much likely to progress to CKD, much likely to double their serum creatinine, much likely to be on dialysis than individuals carrying 0 or 1 copies. Now, apart from just carrying the copies, whether these individuals have proteinuria or not also affects the outcome. So let's move our attention to panel B on the right-hand side, which further stratifies individuals based on their proteinuria. So on the very top line, you see APOL1 low risk group. That means they carry 0 or 1 risk variants, and you're further stratifying them by proteinuria. So regardless of the risk variants, individuals with no proteinuria do far better than individuals with proteinuria. But within each of these subgroups, whether with proteinuria or without proteinuria, individuals carrying 2 high-risk copies or high-risk variants of APOL1 genotype are more likely to progress to needing dialysis down the road. Next slide. So next slide shows you the results of Crick study. The Crick study included whites and blacks, and the black participants were further genotyped based on APOL1 high-risk variants and low-risk variants. And again, you see, and here, these group looked at patients with diabetes on panel C and patients without diabetes on panel D. What you see is the white diabetics and the white non-diabetics had the best outcomes. They were less likely to require dialysis. However, in the dark, solid black line, black individuals carrying high-risk genotype were more likely to require dialysis at follow-up, regardless of presence of diabetes. So what I have shown you so far is in black individuals, with or without diabetes, with or without proteinuria, if they are carrying APOL1 high-risk genotype, then they are more likely to progress to kidney disease, right? So these individuals already have either hypertension or diabetes and some amount of kidney disease. And if they have CKD, then they're likely to progress. So in black individuals who have chronic kidney disease, who have proteinuria, the APOL1 high-risk genotype affects their or accelerates the kidney disease, and they're more likely to require dialysis down the road. Next slide, please. And this slide shows that individuals, what is the effect of standard blood pressure lowering treatment, right? So on panel C, you're seeing individuals based on APOL1 risk genotype, whether they were, their blood pressure was controlled to standard goal of 140/90, or they had a more intensive blood pressure control, more stricter blood control. What we see here, regardless of the blood control, right, the individuals carrying high-risk genotype showed in the red line did much poorly than individuals carrying low-risk genotype. Okay, and as you all know, ACE inhibitors, ARB inhibitors are the preferred choice of treatment for hypertension in black individuals. And despite being on ACE inhibitors, right, individuals carrying high-risk genotype seen in panel D have inferior outcomes regardless of use of ACE inhibitor. So the current management of intensive blood pressure control of using ACE inhibitor does not seem to slow down the progression of kidney disease in individuals carrying high-risk genotype. Next slide. So now we'll move from native kidney disease to kidney transplant. Next slide. And I really think kidney transplant can nail some important issues. Why so? Kidney transplant gives us an opportunity to understand the pathophysiology of APOL1 mediated kidney disease. So, APOL1 protein is produced by the liver. And locally within the kidney, APOL1 is produced by the vascular cells, right? So when an individual who has APOL1 mediated kidney disease, who's on dialysis, that means his own kidneys are not working, the APOL and that individual undergoes kidney transplant, then the APOL1 that is present in that individual comes mainly from the liver, right? Assuming that they got a kidney carrying low risk genotype. Versus if an individual who is carrying low risk genotype gets a kidney from a high risk donor, then you know that the local APOL1 production is responsible for the outcomes of the allograft, right? So, in other words, in this cartoon, let's look at this cartoon here. You have a donor kidney with low risk genotype, and which is transplanted into an individual who carries high risk genotype. Then here in this natural experiment, you will be able to figure out whether it is the circulating APOL1 that is produced by the liver, which is affecting the outcome of the donor kidney, which is not carrying APOL1 high risk variants, right? So I think kidney transplant allows us to better understand as to whether it is the circulating APOL1 that affects the outcomes or whether it is the local APOL1 that is produced within the kidney causing adverse outcomes, or is it both? Next slide, please. So let's first look at, does the APOL1 genotype of the deceased kidney donor, right? Does the APOL1 genotype of the Black donor who's carrying, who's donating the kidney, right, matter in allograft survival? Next slide, please. So the earliest report came out in 2011, right after the Genovese study in 2010. This was published by Wake Forest, where Wake Forest did a single center study of 136 kidney transplant recipients. Okay, they followed these recipients for at least 5 to 6 years, as you see in the graph, and the recipients was classified, grouped based on the donor APOL1 genotype. And we are not only looking at outcomes of kidney transplant where the deceased donor was Black, was of Black ancestry or African ancestry. And all these donors were genotyped for APOL1 risk variants. And then they looked at the outcomes on the kidney transplant recipients. So in blue line here, you see the outcomes in the recipients who got a kidney from a Black donor that was not carrying two copies of APOL1 risk variants. And in the red line, you see outcomes in kidney transplant recipients that were carrying 2 copies of APOL1 variants. And what you see here is that mean follow-up of 26 months, kidneys from donors with 2 copies of APOL1 risk variants had much shorter graft survival. The risk of graft loss was almost threefold higher than individuals not receiving a kidney from donors not carrying high-risk genotype. A third of the graft were lost, and when we look at the histology, most of them had FSGS-like pathology, a pathology that I described before. So while what I showed you this far here is that APOL1 genotype of the donor matters and it causes premature graft loss. But I also want to point out that not every kidney carrying 2 risk variants failed, right? Again, there has to be a second hit. As a result, only some failed prematurely, maybe up to a third failed prematurely, and others did just fine, right? You saw out of the 22, 8 failed prematurely, 30% failed prematurely at 2 years, but the remaining, right? I also want you to remember the point, the remaining 14 did just fine. Next slide, please. So then Dr. Friedman et al. expanded their studies to include over 110 transplant centers, to include the number of participants to over 1,000 to see if APOL1 risk variants in the Black deceased donors still mattered, right? So he confirmed his findings in a much larger study. And here on the right-hand side, you see the survival curves. And the black line is the outcome in recipients who received a kidney transplant from a Black donor carrying 0 or 1 kidney risk variants. And in the blue line is from a Black donor, who carried high risk variants, or 2 APOL1 kidney risk variants. And you see the recipient outcomes varied. Recipients getting a kidney from a Black donor carrying 2 risk variants had a lower graft survival. Okay, but again, I want to point out 73% of the grafts from high risk donors were still working. So it's not an all or none phenomena. While recipients getting a kidney from a Black donor with 2 APOL1 risk variants are at a higher risk for graft failure. Not every recipient loses their graft. Okay, next slide, please. And as I mentioned before, when they took a deeper dive as what caused the allograft failure, it was the same FSGS-like lesion where you see a lot of pink within the filters. And what was the second hit in these patients? Next slide, please. Was thought to be due to rejection. Majority of the people who had FSGS-like lesion had rejection preceding the graft loss, and some of them also had viral infections, as I showed, was a possible second hit in the native kidney disease too. Next slide. Now, let's now look at whether the APOL1 genotype of the kidney recipient matters, right? The person receiving the kidney, does their genotype affect their kidney transplant outcomes? Next slide. Dr. Friedman et al. Genotyped 110 or 100, I think this was from, yes, they genotyped 119 kidney transplant recipients. So now the recipients are being genotyped for APOL1 risk variants, and individuals carrying, there were 58 out of the 119, roughly 50% carried 2 APOL1 risk variants, shown in the dark black line, and the remaining, 51 or 61 carried 0 or 1 risk variants, shown in the dashed line. And as you see, the two curves are superimposed on each other, showing there is no difference in death-censored allograft survival based on the recipient APOL1 status. So until recently, we thought only the deceased donor genotype mattered, but the recipient genotype did not matter. Next slide. However, this was challenged more recently in 2021, where Dr. Menon from Yale University looked at 2 cohorts, GOCAR cohort and the CTOT cohort, individuals getting, with kidney transplant recipients carrying 2 APOL1 risk variants is shown in the blue line. And they genotyped both the donor and the recipient and showed that recipients carrying 2 risk variants of APOL1 gene or high-risk genotype did have inferior outcome. Next slide, please. And there was another study from Brigham's that also confirmed the findings that the recipient APOL1 status did matter and did lead to poor outcomes after kidney transplant. Next slide, please. So, in summary, I think we have conflicting data whether the number of APOL1 kidney risk variants in the kidney transplant recipients affect the clinical outcomes after transplant. And if they do, some studies have proposed that it is due to rejection or perhaps due to viral infection. Next slide, please. So now, we all know that transplant from a living donor is far, far better than getting a kidney from a deceased donor, which is far, far better than remaining on dialysis, right? And generally, it's your family members, right? Or who want to donate a kidney to you, who want to help you. So now we are talking about, among Black individuals, it's likely that their family members want to donate, and it is possible that the family members share that same genetic factors, which is APOL1 genotype, and whether the APOL1 genotype matters in living donor outcomes. So you have an individual, a young person who wants to donate to his dad and has APOL1 genotype. Should you allow that young individual to donate? Yes, no. So we'll try to answer that question in the next few slides. Next slide, please. So first, let's take a step back. Okay, let's look at the risk of end-stage kidney disease in living donors as compared to healthy non-donors, right? We all know that the living donors undergo extensive testing before they're allowed to donate, right? You have a recipient, a candidate who's already sick, who's on dialysis, right? I cannot change the outcome for that patient, but I don't want somebody otherwise healthy to donate and then risk their lives, right? As a result, living donors go through extensive testing. So it is not fair to compare the outcomes of an individual who's gone through extensive testing and allowed to donate to just anybody, right? So as a result, in this study, Dr. Mazzali et al., he looked at outcomes, likelihood of developing end-stage kidney disease in living donors, shown in the blue line, and compared it to healthy non-donors. That means these were individuals who did not donate, but were screened for good health at baseline, right? And their risk of end-stage kidney disease or their risk of needing dialysis down the road is shown in the dark black lines, right? So you're comparing the risk of end-stage kidney disease or risk of needing dialysis down the road in living donors in blue line as compared to healthy non-donors in the black line. And you're now doing this comparison across races. So you have Black individuals on the extreme left, Hispanics in the middle, and white individuals on the extreme right. What you see is, regardless of the race, live kidney donors are more likely to develop end stage kidney disease or require dialysis than healthy non donors, right? And the cumulative risk of end stage kidney disease is highest in black, like it's the tallest blue line is in the black cohort. And the difference of development of end stage kidney disease between non donors and living donors, that is shown in that red line, the red bracket, is highest in the black living donors. So not only the black living donors have a highest cumulative risk of developing end stage kidney disease, but the absolute risk increase, perhaps due to donation, is highest in the blacks. But I also want to tell the audience that this risk is far, far lower. What you see here is 70 per 10,000 donors for the black is far lower than what is seen in unscreened general population for black individuals, which is in the estimates of 300 per 10,000, right? So while I'm showing you that the black donors have a slight increase, the risk as compared to the general population is very, very low. Okay. Next slide, please. So we want to go back and look at who are these black donors who are getting kidney disease. So this slide shows you comparison of outcomes between biologically related donors and biologically unrelated donors, right? So it's the recipient donor relationship that matters, that affects the risk of post donation and development of end stage kidney disease, which makes sense, right? The donors and the intended recipients are family members. They share the same genetic and the familial and the environmental factors. And as a result, the donors might be at a slight risk of developing end stage kidney disease. So we want to see if we can further, uh, risk stratify our donors who are biologically related to see if we can use some testing, such as APOL1, to further stratify the risk of kidney disease. Next slide, please. So myself and Dr. Goggins from Henry Ford, we went and genotyped 136 Black living donors who had donated at two centers in Detroit, at Harper Hospital and at Henry Ford. And they had donated roughly 10, 15 years ago. We genotyped them. So 19 donors carried two risk variants, were labeled as high risk genotype, and 117 carried 0 or 1 risk variants and were labeled as low risk genotype. So then we went back and looked at the outcomes in these two groups of donors. Next slide, please. And we published our results in Journal of American Society of Nephrology. So let's look at the figure on the left. Okay, figure 1. So first we compared the pre and the post donation kidney function based on APOL1 genotype. So the first column on the left-hand side, where you see the red graphs, shows you outcomes in Black living donors who had donated and carried low-risk genotype. And the black figure on the right-hand side shows you pre-donation kidney function and post-donation kidney function among donors carrying high-risk genotype. What you see here is individuals or living donors carrying high-risk genotype had lower kidney function prior to donation, but that was acceptable. And as a result, also had a lower post-donation kidney function at follow-up. And that difference was statistically significant, as you see, by p less than 0.05. Two donors in the high-risk genotype group. So we had 19 donors in the high-risk genotype group, out of which two donors went to develop end-stage kidney disease. Now, let's focus on the right-hand side, figure 2. As I mentioned previously, donors carrying high-risk genotype have a lower GFR, still normal, within normal range, had a lower GFR prior to donation, had a much lower GFR than the low-risk group after donation. The question is, do they have lower GFR after donation because they started low, or did they have a faster decline in their kidney function after donation, right? So to answer this question, we compared the trajectory of GFR between the low-risk group and the high-risk group. So figure 2 shows trajectory of GFR after donation in the low-risk group in the red line and the high-risk group in the right, in the black line. What you see is individuals, not all, some individuals in the high-risk genotype had a much faster decline in their kidney function after donation than as compared to donors in the low-risk group, okay? And that difference was statistically significant. Again, as I said, we had a closer look at all the individuals in the high-risk genotype, and not all 17 individuals who did not require dialysis had a nosedive in their kidney function. Some of them had stable kidney function years together. So again, showing that there has to be a second hit for some individuals who have donated, who are carrying high-risk genotype, have an accelerated decline in their kidney function after donation. Next slide. So the question comes is, does donation affect the outcome between APOL1 associated kidney disease or no? In other words, if an individual who has APOL1 high risk genotype, if they were to donate, does donation alter or the association between APOL1 and kidney disease? Does it hasten the progression? To answer that question, we compared the GFR trajectory between non-donors, shown in the black line in the two pictures, and compared it to donors, okay, in the red line. The non-donors were matched to donors based on age, gender, duration of follow-up, family history of kidney disease, and APOL1 status. So you see on the left-hand side, you have comparison in the low-risk group. On the right-hand side, you have comparison in the high-risk group. What you see is the two curves are parallel, suggesting that donation does not affect the outcome of APOL1 associated kidney disease. Next slide, please. So we concluded APOL1 high-risk genotype in Black living kidney donors is associated with lower pre and post-donation kidney function, and some donors may experience a faster decline in kidney function after donation. Not all donors with high risk genotype had an accelerated decline in their kidney function. While high risk genotype, in that last figure that I showed, did not modify the association between donation and rate of decline in kidney function, individuals with high risk genotype who have lower GFR after kidney donation may experience faster decline in the kidney function and may reach ESRD sooner. So perhaps we need to perhaps do APOL1 testing in select donors and based on the risk factors perhaps recommend them not to donate their kidney. Sorry. Next slide, please. So, what do we tell the healthy relatives of patients who are carrying APOL1 gene mutation? What do we tell a person who is in your office who wants to donate to their loved one about APOL1 gene when they're otherwise totally healthy? Or what do we tell to our patient with CKD in the clinic who wants to know what should they tell their loved ones at home, whether their relatives should undergo genetic testing, and how much should they worry about their future risk of kidney disease, right? So we're talking about healthy relatives of patients getting APOL1 gene mutation. Next slide, please. So what do we know? What have we learned from the living donors, right? What are the risk factors of developing end-stage kidney disease post-donation, right? And this study was done by Muzali et al. And he looked at risk of end-stage kidney disease in donors stratified by race. So dashed lines represent Black donors. Solid line represents non-Black donors or white donors. And the different colors represent the age of the donor, right? So the green lines, let's just focus. So the green line represents donors who are more than 45 years of age. And you see the dash lines and the solid lines are superimposed. So young Black donors, right? Because if you see overall, the dashed lines, the risk of end-stage kidney disease is highest. That means in Black donors, the risk of end-stage kidney disease is highest, and it's highest in the ones that are, pink or blue, and they are donors who are age 45 or under. For donors who are age 45 and over, shown in the green line, there is no difference by race. So this slide suggests that perhaps the risk of end-stage kidney disease is higher in the younger people who have not had chance to manifest the disease, right? So we should be more careful when we are selecting a young donor. We are accepting a young donor to donate a kidney to their loved ones or to their family members. Next slide. And this finding was further strengthened by Dr. Lackey's paper that was published in Annals of Surgery in 2018. In 2018, where she looked at all young individuals aged 18 to 25 and who were healthy at baseline, had good kidney function, did not have diabetes, did not have hypertension, and looked at the risk of kidney disease. That means GFR less than 60 at 25 years of follow-up. Hazard ratio gives you the risk of kidney disease, right? And let's focus at the very bottom. You see APOL1 risk group references European Americans. So young Black individuals have higher risk of developing chronic kidney disease, GFR less than 60, regardless of number of APOL1 risk variants they carry. But the risk is highest in young Black individuals carrying two risk variants shown in that last line at the bottom, where the risk is almost five-fold higher, right? So again, this study exemplifies that young individuals who are good with good baseline health are at higher risk for developing kidney disease if they are carrying two risk variants. Next slide, please. So this is a study that I recently did and is accepted in Kidney Medicine and will be published soon. So to answer the same very question, I was like thinking, what about individuals who are 45 years old or above? So I looked at the ERIC cohort, and selected this ERIC cohort has has enrolled individuals age 45 to 54, so in that middle age group. Out of that ERIC cohort, I limited my analysis to individuals who would be selected as living donors or would be accepted as living donors. That means they had good kidney function at baseline. Kidney function was more than 80 ml. They did not have hypertension. They did not have diabetes. They were not obese. They did not have any cancer. And then looked at risk of end stage kidney disease at follow up, right? So I compared the risk of end stage kidney disease between the whites shown in the green line, individuals with low risk group in the red line, and those in the high risk group in the blue line. What do you see? It's all superimposed. So the race doesn't matter and the genotype doesn't matter in older cohort, because I believe that that older individual has had chance to manifest kidney disease if they were going to manifest one, right? So I think the APOL1 genotype in the living donor, particularly in the older cohort, does not matter. Next slide, please. So what about treatment, right? So I've shown you so far that the APOL1 genotype matters in individuals with kidney disease. Individuals that have already developed kidney disease, particularly those with proteinuric kidney disease, APOL1 genotype does affect outcomes. It is possible that the APOL1 genotype of the deceased donor may affect transplant outcomes. It is also possible that the APOL1 genotype of the recipient may affect outcomes. How can we treat this? Next slide, please. So there are so to understand treatment, let's go back and look at how, how does a gene cause effect, right? So you have APOL1 gene, which is a DNA, which is present on your DNA, right? Which is present within the nucleus of the cell. That DNA has to be converted to an mRNA. So that is called the APOL1 transcript. So that codes, that sends the coding outside the cell, the nucleus, for the cell to create a protein, which to generate your APOL1 protein, right? So the DNA has to be then converted into mRNA, carry the code to make the protein, right? So the current therapies are targeting either with CRISPR to alter the DNA or to create an antisense mRNA targeted therapy, or currently there is a therapy that inhibits the action of APOL1 protein. So it's really exciting time when there are a lot of different treatment options targeting different time points that at the end ultimately results in formation of APOL1 protein. Next slide, please. So this was a paper published in New England Journal of Medicine just a year ago, where they looked at inaxaplin for treatment of proteinuric kidney disease. This is a molecule that inhibits APOL1 protein, which is thought to create those pores in the podocyte and cause damage to the podocyte. So inaxaplin was given to 13 patients, as you see in the box there, who had proteinuric kidney disease, had proteinuria anywhere from 3.5 grams to 1.8 grams. And after treatment with this drug, what you see at week 13, they all had a reduction in proteinuria at least by 47%. So this is really encouraging. And there are, next slide, please. There are clinical trials underway, phase 2, phase 3, looking at the effectiveness of the small molecule in treatment of APOL1-mediated kidney disease to see if we can halt the progression of this kidney disease. This is so exciting to see a gene getting discovered just within the last 15 years, and now you're to witness, treatment already based on the alteration in the gene. Next slide, please. So where do we go from here, right? We have some unanswered question. At least in native kidney disease world, we know that individuals carrying high-risk genotype, particularly if they have proteinuria, are more likely to progress. We discussed new treatment options that might be soon available to everyone for treatment. There are studies underway to assess the efficacy and make sure that these treatments are safe. Unanswered question mainly remains in the realm of transplant, and we believe that that these transplant trials will also help us understand the second hit. What is that second hit that causes some people to fail their kidney prematurely and other individuals who are carrying this high risk variants do just fine, right? So, next slide, please. So, we have this multi center Apollo study currently underway that aims to study transplant outcomes of all kidney transplants that have been performed uh, uh, using kidneys from Black deceased donors. So this study is, again, as I said, nationwide. With 260 transplant programs are participating across the country, 58 OPOs, and to date have enrolled several thousands of deceased donor kidney transplant pairs and have also enrolled several living donor pairs to answer this question as to whether the APOL1 genotype of the deceased donor affects recipient outcomes. They're genotyping the recipients to see if the APOL1 genotype of the recipient affects the outcomes. They're also genotyping the living donor to see if the transplant outcomes based on the living donor genotype are also different. Next slide, please. And there are studies underway to see if the APOL living donors also, right? To see if individuals or living donors carrying APOL1 genotype have a more inferior outcomes with regards to the kidney function as compared to individuals not carrying such high risk genotype. There are several other studies about identifying and exploring solutions to ethical challenges of APOL1 testing, particularly in transplant setting where such little is known currently. And how do we integrate a culturally competent APOL1 genetic testing program into living donor evaluation? So I think a lot of studies, great studies are underway and a lot more to come in the coming years. Next slide, please. So, a little bit, because so much is unknown, I think it is very important to be transparent and to counsel patients both before and after APOL1 testing. Transplant counseling can be performed by a general nephrologist, transplant nephrologist, or a member of the transplant team, or a genetic counselor. It should definitely be offered before genetic counseling and again after obtaining results. At least in the transplant world, definitely acknowledge that there is lack of robust data and that not every individual, again, I really want to hone this down, not every individual carrying two risk variants is going to get kidney disease. We need a second hit for the kidney disease to manifest. The good news is there are newer treatment options to treat individuals who have kidney disease due to APOL1 mediated, due to APOL1 high risk genotype. There are several work groups talking about how do you counsel, what elements should you cover during these counseling, and these work groups support shared decision making between the transplant team and the donor, at least for now. And lastly, the team wants to say isolated finding of two APOL1 risk variants should not be sufficient to rule out an otherwise healthy candidate, except like when you have a very young donor, who's 20 or 30 years old, has strong family history of kidney disease, then perhaps you want to seek an alternative donor. Next slide, please. So these are the main key takeaway from this talk. And I've classified based on native kidney disease, transplant recipient, living donors, and what do we tell the healthy family members of individuals who have chronic kidney disease and have APOL1 gene variants. I think everybody should be informed about APOL1 gene across the board, whether it is patient with native kidney disease, whether it's a recipient, whether it's a living donor, whether it's the family member. But testing for now should be just reserved for few. If you have a patient with kidney disease, proteinuria kidney disease with African ancestry, then you should check them for APOL1 mutation. And as I said, there are treatment options underway which you could offer to this individual in clinic. And selected living donors, young, those with some risk factors, should be screened for APOL1 to better risk stratify for their future risk of kidney disease. Okay. And again, I want to say not every individual carrying APOL1 gene will develop kidney disease. And next slide, please. And I think that's the end of my talk, Mike.
Thank you very much, Dr. Doshi. I appreciate it. And we're going to jump right into Dr. Patel to talk a little bit about the work that the Kidney Health Initiative is doing in this area.
Great, thanks. I just want to thank Mike, Jamitra, and everyone at AKF for being part of this Kidney Action Week. It's very exciting, and thanks to Dr. Doshi for a great overview of APOL1 and why it's so important that we need to discuss this sort of as a kidney community. Next slide. Maybe to share a little bit about what KHI is doing, I'll start with our mission statement, which is to catalyze innovation and development of safe and effective patient-centered therapies for people living with kidney disease. And really aligned with this mission, you see our 2024 goals are listed, and advancing sort of collective efforts for APOL1 associated kidney disease is really important part of this. Next slide. So how does KHI do this? It really is, I invite you to look more at our website, but in brief, it's a pre-competitive organization that seeks to raise the tide for all boats of individuals and organizations trying to develop new therapies for people living with kidney disease. We're fiercely patient-centered, community-led, and community-developed. And so, as a public-private partnership between the American Society of Nephrology and the FDA, we also work very closely with several key centers within the FDA focused on drugs, biologics, and devices. Next slide. You heard a lot about some of Dr. Friedman's work. I'm going to skip this next case presentation. It's wonderful. I'd recommend everybody go check it out. Next slide. It goes through the journey of a lot of patients with APOL1 who have strong family histories of developing kidney failure and often initially show up with hypertension and wonder about their journey. And so APOL1 has really been a phenomenal discovery in the kidney field, and now we're on the verge of having therapies available. So it's important to figure out how we're going to address this in terms of improving awareness, detection, and possible treatment. Next slide. So a few years ago, a bunch of folks got together and tried to examine the current sort of state of affairs of nephrology views, community views, and other key stakeholders, and really found that there's pretty good awareness among kidney providers, but not among a lot of other key stakeholders to sort of help make this something that's actionable, particularly among the patient community. And so low levels of awareness not only limit the ability to detect, but then have the ability to potentially be part of studies that can help advance therapies, but then eventually when they're available, even receive those therapies. So this is something KHI wanted to address. Next slide. Really along the axis of awareness, genetic testing, and potentially study participation. So a lot of different things to sort out. And with that, next slide. In 2022, we initiated a roadmap to establish sort of ways to increase awareness of APOL1, increase access and awareness to genetic testing and the associated counseling to make that actionable, and then also finding ways to empower patients to make informed decisions about clinical trial participation. This was a multi-stakeholder event, took a year to develop, generated over 40 action items, and they're meant to really prompt action among the community, not any one individual stakeholder. And it's nice to see AKF picking up that baton and working with the community to sort of have this Kidney Action Week and a number of other efforts focusing on APOL1-mediated kidney disease. Next slide. There's a number of audiences that are relevant to this, so I invite everybody to go check out this roadmap online. But maybe in the interest of time, we'll jump to a few slides forward to sort of why this roadmap is important. In the roadmap, you'll see all of the different components, the main challenges, potential solutions. But what I want to highlight is, maybe go slide forward 4 slides. I know we're running over, so I'm just trying to catch up here. 2, 3 more or 4 more. I think one of the takeaways from this roadmap is that it's really a call to action for the entire community. And it's exciting to see this Kidney Week action related effort. It's going to take collective action, and together we really think we can increase awareness of people of African ancestry, increase APOL1 genetic testing, and empower those at risk to make informed decisions about participating in clinical studies, whether or not that's a trial or just trying to learn more about the disease process and risk factors, like you heard about. And just 2 more slides forward, I think will get us to kind of a summary slide that we can end on. Really, I think with the verge of these therapies being available, it's important to really start to address this now so that they can have an impact in the community and help reverse some of the outcomes that you heard about by Dr. Joshi, but also a lot of other descriptions of how, just APOL1 might be responsible for almost 70% of the excess burden you see among people with kidney failure who are of African ancestry. So with that, I'll end, and again, thank the AKF for the opportunity to share a little bit about what we're doing, and look forward to working with you.
Well, thank you very much, Aptal. Really appreciate it, and we really appreciate the work that Kidney Health Initiative is doing, and glad to be part of all the efforts there. If I could just go through and talk a little bit about some of the resources that the American Kidney Fund has regarding APOL1-mediated kidney disease. I think it's good for everyone to be aware of what we've got. Next slide, please. So we have done a lot in this area. Obviously, this is one of many different things that we've been trying to do to raise awareness about AMKD Day, AMKD. And one of those ways is through our AMKD Awareness Day, which is coming up on April the 30th. And I'm sure my team is probably already dropping into the chat, way in which you can save the date and find out how you can participate in that. There are lots of other ways that your organization can help us do that. You either partner with us as pushing out for social media. We have some states that we're looking for proclamations for AMKD Awareness Day, and we have opportunities for how to do that on our website as well. Next slide, please. And then, we also have resources for you as a clinician, but also for your patients. Dr. Doshi did another professional webinar for us last year, and we had a great overview fact sheet that is available on that site as well. We've got patient testimonials. You can hear from patients themselves with some video stories that we have on that site. We have information on clinical trials that are happening now, not just on trials in general, but, AKF has partnered with a company called Antidote, who presented at last year's Kidney Action Week, to really have a way for patients to search for clinical trials in ways that is meaningful to them and makes sense. So you can find that on the AKF website as well. And then, one of the things that we've been a great resource to healthcare professionals is providing patient resources to professionals to give to their patients. You all know how difficult it is when you're trying to get the most key information to patients as quickly as possible in the amount of time that you have. And we're here to do that as a trusted resource. So please know that you have those available to you. Lots of education content on that. We've animated explainer videos that you're welcome to use. And guides for working with a genetic counselor, which is a huge part of this. You heard Dr. Weir talk about that in this morning's first presentation, but the importance of having that genetic counselor piece attached to this as well. Next slide. And I mentioned AMKD Awareness Day on April the 30th. Again, this is a nationwide campaign to raise awareness about AMKD. We have lots of partners already joining on to help us with this. Again, as I mentioned, we are looking for those to help submit a proclamation for your state. I think we're at like 20 or 24 states the last I heard, so we've still got plenty of room and need your help to do that. Our government affairs team can walk you through it, but there's also a step-by-step guide on our website. And share resources with your patients leading up to that day as well. We want to do all we can, as Dr. Doshi said, to at least raise awareness about this. That is really the idea behind our work, is to get this in front of as many patients as possible. And whether or not they decide to get genetic testing will be a decision with their physician and their family and their genetic counselor. But we at least want to get the information out there. Next slide. So again, just some key takeaways. Make sure you're educating patients about AMKD. In those cases where Dr. Doshi talked about, potential living donors, if you already have an active kidney disease at a young age and you're not really understanding what's happening, talk to your patients about genetic testing, get them in touch with a genetic counselor to figure out, what is best for patients. Make sure they understand any risks related to life insurance, disability insurance, those kinds of things. And again, just making sure that you are talking to patients about all of their options related to the kidney disease and get them identified as early as possible. And with that, I think we have time for maybe just a couple of questions. I know we're over just a little bit, but if Dr. Doshi, if you're willing, I could just maybe send a couple of questions. I'll just ask my team if they've gotten any from
Sure.
the audience. But in the meantime, Dr. Doshi, how do you see this relating to, the Kidney Precision Medicine Project? What's the crossover there with AMKD and how those things might relate and move forward?
I think as more and more therapies come along, genotype will be part of the panel when you see a patient with kidney disease, right? Particularly with African ancestry. And I think, and then not just APOL1, as I mentioned recently, there was a gene published that protected individuals with carrying APOL1 from getting kidney disease. So we might find those second hits, either other genes that protect individuals or genes that amplify the injury due to APOL1 high-risk variant. So I think more to come.
And can you explain, we had a question from someone in the audience about when you have a single APOL1 risk variant, the question being, does that mean one came from the mother and not the father, or vice versa? Can you explain a little bit about kind of how that's passed down familial?
Yes. So when you have one, it either came from one of the parent. And because it's a recessive gene, you need both copies. So you need one from each parent for you to be at high risk for APOL1-mediated kidney disease.
Great. Okay. Let's see if we got any other questions in. I think that may be it. Well, Dr. Doshi, I want to thank you very much for your time today, for everything that you've done and continue to do for the Apollo project and for us at AKF. I really appreciate it. And that is actually going to conclude our session for today. Tomorrow we have our last day of Kidney Action Week. I can't believe it's here already. But we'll start tomorrow at 10 a.m. Eastern time on our final day of Kidney Action Week, talking about innovation. So we'll have 8 different quick presentations about all of the great things that are happening in the field of innovations in nephrology, including some information on xenotransplantation. You may have seen the news today that there was the first pig kidney transplanted into a patient today. We actually have one of the pioneers of that work speaking tomorrow. So please join us tomorrow. As we close, you will see a survey come up in the chat box. Please fill it out. Let us know how we're doing. And we will see you all tomorrow. Thanks again to our speakers. Thanks to all of you.